Hi everybody, my name is Mitchell Farmer, and I'm going to be talking today about Laboratory 1 of GI block, or the anterior abdominal wall. I'm going to start with looking over osteology, and the first thing I'm going to look at of that is the bony framework of the abdomen. So the bony framework of the abdomen consists of four relevant boundaries: the posterior, superior, inferior lateral, and inferior boundaries. So I'm going to start with the posterior. So I'm rotating to the lateral aspect of my model. Just recall, this is anterior, this is posterior. So starting with the posterior boundary, we have the five lumbar vertebrae, or L1, L2, L3, L4, L5. Rotating back anteriorly, we can look at the superior aspect of the bony framework of the abdomen, which is the inferior thoracic aperture. So the inferior thoracic aperture is formed by the edges of the lowest ribs, like this. Now, the inferior lateral part of the bony framework of the abdomen is the iliac portion of the os coxae. Now, the os coxae is just another term for the pelvic bones, and there's three of them: the ilium, the pubis, and the ischium. So the inferior lateral portion of the bony framework of the abdomen is the ilium, or the iliac portion of the os coxae. Now, the inferior portion of the bony framework is the pelvic brim, which is, as I zoom into the pelvis here a little bit, is a bony ridge created by the three bones of the os coxae that I'm kind of circumscribing right now. You can see it. I'll kind of rotate just to show you it a bit better here. Now, the pelvic brim, which is the same as the pelvic inlet, is also the inferior aspect of the false pelvis. The false pelvis extends between the pelvic brim and the iliac crest. Now, the iliac crest is just the top of the ilium, and that's the false pelvis. Below the pelvic brim is something known as the true pelvis, and houses most of the pelvic organs and the pelvic cavity. And I'll talk a bit more about that when reprobot comes around. So above the pelvic brim, false pelvis, which is also the bony framework of the abdomen. Below the pelvic, or is the inferior aspect of the bony framework of the abdomen, below the pelvic brim is the pelvic cavity. Now, I wanted to show you a couple structures specific to the ilium, as I'm going to be using those structures to landmark throughout the rest of the lab. So I'm going to go into something I call multicolor mode, which takes away every other structure and shows me highlighted structures of a specific bone. So this is the ilium: lateral, medial, anterior, posterior. So as already discussed, this is the iliac crest, which is the top of the false pelvis. Then there's also something known as the ASIS, or anterior superior iliac spine, as seen here. This is a landmark for a whole bunch of things I'll be discussing throughout the lab. And then here is the tubercle of the iliac crest, which is an important landmark for when demarcating the 9 regions of the abdomen for surface anatomy, another thing I'll be discussing. As far as the rest of these highlighted structures go, I'll be discussing them more in MSK and Repro when I look into the os coxae with more detail. So enough of the hip bones for now. The next thing I'm going to move on to discuss is just discussing the lumbar vertebrae in a bit more detail. So as you can see, the lumbar vertebrae have somewhat of an anterior curve to them, or a lordosis. This is anatomically significant in part because this curvature brings the abdominal aorta closer to the anterior abdominal wall, making it potentially damageable or palpable on physical exam. Now, selecting a specific lumbar vertebrae, I'm going to go back into that multicolor mode so that we can look at a few more structures in detail. So this is, just to reorientate you, this is anterior, this is posterior. So starting anteriorly, we have the body, which is the weight-bearing structure of the lumbar vertebrae. Posterior to that, we have something known as the pedicel, and the pedicel is connected to the lamina, this section here, via a structure known as the pars interarticularis, which is a bridge between the pedicels and the lamina. So the pars interarticularis isn't a colored structure in this representation, but it's prone to fracture and degeneration, as you will find out in MSK. So it is an important structure to know. So if we continue posterior from that, we can see the lamina, this highlighted structure here. And this encloses the vertebral canal, as seen here, which houses the spinal cord. Posterior to that, we have the spinous process, directed posteriorly, so posterior, anterior, and I'm looking at it from a superior view, directed posteriorly at the midline, and it's a site of ligament and muscle attachment. The other processes of interest include the transverse process, which exists on, or processes, which exists on either side laterally of the vertebrae and are another site of muscle attachment. And then there is also the superior articular and inferior articular facets, or processes. Now, their vertical orientation, or the vertical orientation of the superior and inferior articular facets, progresses from the sagittal plane superiorly, so L1, L2, to a more coronal orientation at the L5-S1 interface. This is difficult to show on the model, but it's important because it minimizes lumbar mobility in the transverse plane, so rotating your back, but it allows for flexion, extension, and lateral flexion. I'm just going to exit out of this multicolor mode now, and very quickly, for the last thing I want to talk about for the lumbar vertebrae is discuss the lumbar puncture. So the lumbar puncture typically takes place between L3 and L4, or L4 and L5. Now, the reason this happens is because below the level of approximately L3 or L2, the spinal cord no longer exists. Instead, a structure known as the cauda equina exists, which is a bundle or a collection of loose nerve roots bathed in cerebral spinal fluid. So as you put a needle in, say between L4 and L3, into this space, instead of hitting a nerve root, they can float out of the way because they're bathed in cerebral spinal fluid and not confined by the spinal cord. And that's why this is a safe place to anesthetize someone, as opposed to, say, doing it between T12 and L1, where you'd probably strike the spinal cord and injure a nerve. This will be talked a lot more about in MSK, so if you don't get it right now, that's okay. So the next thing I want to discuss is the surface anatomy, and more specifically the 9 regions of surface anatomy. I'm going to leave the 4 quadrants for physical examination, where they're talked about in a lot more detail with in that stream. So instead, the 9 regions. Basically, the 9 regions are kind of like a game of X's and O's, where you have 4 lines that break it up into 9 regions. 2 of the lines, the 2 vertical lines, exist in what's known as the mid-inguinal plane. So the mid-inguinal plane is basically the center or the midline of the inguinal ligament, a ligament that extends between the ASIS, I'm just going to hide this, the ASIS, anterior superior iliac spine of the ilium, and the pubic tubercle of the pubis bone. And this is the inguinal ligament. So if you draw an imaginary line halfway through that, extending vertically, superior, on either side, those are our first 2 lines. Now, the next 2 lines that we're interested in are the subcostal plane, which exists subcostal, below the ribs, at the lower aspect of the lower ribs. If you extend a line between the lower aspect of the lower ribs on the left to the same on the right, you'll get another line, and then the final line is called the intertubercular plane, which is the tubercle of the ilium, this bone right here. This is the tubercle. So extending from one tubercle, the left one, to the other, the right one. And now you have 9 visible planes. The middle one is the umbilical. The top one is the epigastric. Below that is the hypogastric. And then our lateral planes are known as the left hypochondriac here, right hypochondriac here, left lateral, right lateral, left inguinal, and right inguinal planes. So that's about as much as I'm going to talk about for surface anatomy. Skin isn't super well done in this model. It's kind of just uniform, and you select one structure and it turns everything blue. It's not super useful. So I'm going to move on to layers of the anterior abdominal wall. And of course, the outermost layer is skin, which I'm going to hide. So below skin in the cadaveric dissection, you will see superficial fascia. Unfortunately, fascia is another thing that's not super well done in the 3D models, but you will see superficial fascia, but we don't see it here. But what we do see is some superficial nerves, specifically the anterior cutaneous nerves in the midline, which are terminal portions of the lower intercostal nerves, and they aid in supplying the rectus abdominis muscle. Whereas if we move laterally and look at the subcutaneous space near the mid-axillary line, we can see the lateral cutaneous nerves, and you can see how they extend down like this, and similar goes for the anterior nerves. They're kind of like segmental as they come off the intercostals. The next most obvious thing is the external oblique or external intercostal muscle, which is part of one of the three trilaminar muscles, the other two being the internal oblique deep to the external, and the transversus abdominis deep to the internal oblique. But starting with the external oblique, we have it arises from the lower 8 ribs, as can be seen here, and inserts onto the linea alba, a ligamentous structure extending from the xiphoid process to the pubic symphysis, basically a cartilaginous joining of the two sides of the two pubis bones. And it also inserts onto the pubic tubercle, as previously discussed, the site of insertion of the inguinal ligament, as well as the anterior half of the iliac crest. So if you remember, this is the ilium, the iliac crest is the very top of it, anterior half is another place where the external obliques insert. And finally, the lower edge, or the inferior edge, helps form, or does form, the inguinal ligament, which I'll talk a whole bunch more next lab. Now, if I remove the external obliques from either side, we reveal the internal obliques on either side. And if I remove the internal obliques, say from the left side, you can see how the internal obliques are superficial to the transversus abdominis. And below the transversus abdominis, or deep to the transversus abdominis, is the transversalis fascia, and deep to that is the peritoneum. The peritoneum being kind of the thin structure that overlays the abdominal cavity, the abdominal viscera, which I will talk about in great depth when we get to later labs in GI block. But one of the most prominent structures we can see is the rectus abdominis, or abs, so to speak, present at the midline and variably present as we move laterally. Sometimes it extends farther in some people than others. Now, the rectus abdominis attaches to the xiphoid process, the cartilaginous portion of ribs 5 through 7. So this is rib 5. You can see how you have this osseous portion. And then as we go towards the midline or medially, we get a cartilaginous portion where the rectus abdominis would insert. And then the rectus abdominis originates from the pubic symphysis. Now, the interesting thing about the rectus abdominis is that it is enclosed by the aponeurotic layers, or the aponeurotic layers of the trilaminar muscles. So recall the trilaminar muscles include the external oblique, internal oblique, and transversus abdominis. And those have, as you can see here, kind of like a ligamentous or fibrous layer that we call aponeurotic layers. And the three of those layers help form something known as the rectus sheath, which encloses the rectus abdominis, or overlays the rectus abdominis. But the interesting thing about the rectus sheath is that it changes above and below the anterior superior iliac spine. Recall, this is the ilium, this is the anterior superior iliac spine. Above the ASIS, so I guess you could say above this line between the two ASIS, the posterior sheath of the rectus sheath, so on the posterior aspect of the rectus abdominis, is the aponeuroses from the internal oblique and transversus abdominis. The anterior side, or the anterior sheath, is the external oblique aponeuroses and the internal oblique aponeuroses. And that's above the level of the ASIS. Below the level of the ASIS, the aponeuroses changes. So now the aponeuroses of the three trilaminar muscles are all on the anterior aspect of the rectus abdominis. So they all go anteriorly and none of them go posteriorly. The only fascia that exists posteriorly is the transversalis fascia. And this change is actually visible on this model. If we look at the transversus abdominis here, we can see that below the level of the ASIS, its fibers are above or superficial to the rectus abdominis, whereas above the level of the ASIS, they are below or deep to the rectus abdominis and they are not visible. Now, there's some really good diagrams, especially in Lemlin's lectures, that kind of clarify what I'm talking about. So if you need that, just check it out, and then hopefully that concept will become clear to you. Now, finally, the last thing I wanted to talk about is the... so I'm just getting rid of a couple things here. Is the vessels of the anterior wall, two to be specific, the inferior epigastric and the superior epigastric. So I'm going to rotate laterally. This is the rectus abdominis. I'm going to rotate laterally, so we're looking at the posterior aspect of the rectus abdominis. So this is the posterior aspect of the rectus abdominis. And what we have here, these two vessels that we can now see, is the superior epigastric, which is found on the posterior surface, and the superior half. So the superior half of the rectus abdominis on its posterior surface is the superior epigastric, whereas on its inferior surface, on its posterior, or inferior half on its posterior surface, is the inferior epigastric veins. And these are going to become especially important when it comes, the inferior epigastric that is, are going to become especially important when it comes to sorting out indirect and direct hernias next lab. All right, rotate back around here anteriorly, and I think that that's everything I want to talk about this lab. Thank you very much for your time, and I will see you next lab.